Welcome, everybody. My name is Philip Watts, and I'm the interim CEO of Mental Health Reform. Firstly, on behalf of the team and the board of Mental Health Reform, thank you all very much for joining us today online for our Coalition Conversations webinar on suicide prevention. For those who are joining us today for the first time, Mental Health Reform grew from the Irish Mental Health Coalition, which came together in 2006 with the 5 founding member organisations, including Shine, Bodywise, Grow, Irish Advocacy Network and Amnesty International. It was renamed Mental Health Reform in 2011, and now we're in our 13th year with 86 member organisations. The organisations, our main focus of our work over the last while has been on issues such as the Mental Health Bill, which was got its second reading in the Dáil very recently, and also, of course, adequate financing for mental health services, including those provided by voluntary organisations. And we were glad to see the allocation in the budget for 2025 of increased funding for mental health services. So Mental Health Reform's Coalition Conversations webinar series provides a platform to explore new developments and innovations in mental health and to facilitate knowledge sharing within the mental health sector. Today's webinar will examine progress in suicide prevention since the launch of Connecting for Life in 2015 and aspirations for the new suicide prevention strategy, which will be published in 2025. Speakers today will discuss suicide prevention initiatives across the island of Ireland to encourage collaboration, learning and knowledge sharing. The webinar will feature stakeholders from the mental health sector in Northern Ireland, people with lived experience, and our own members who play an integral role in the implementation of Connecting for Life. Mental health difficulties affect so many of us, and there should be no shame in that. Today, we all share a common goal to ensure that everyone can access the right services where and when they are needed, to ensure every person in society can reach out and access the supports and opportunities that give the chance to achieve our best possible mental health. With this in mind, please be aware that the topics today covered under this webinar may be triggering. So if you have any needs for support, please text HELLO, HELLO, to 50808 50808 to start a conversation. The service is anonymous, free, and is here for you 24/7. You can also visit the MHR website to access our members' information who provide a number of supports. So thank you again for joining us. I look forward to working with you in my phase as interim CEO, and thank you in advance to all our speakers and panelists as being part of the coalition conversations. I look forward to the discussions. Over to you, Burr.
Thanks so much, Philip. Good morning, everyone. We're delighted to have so many of you here this morning. We've loads to get through. And I'll just remind everyone that we have the ISL interpreters, and you just need to be in speaker view to be able to see the interpreters. So Stephen is going to be clicking through the slides, but just to say, I'm presenting some of the information that our research officer, Julia Corey, did on our submission on the Connecting for Life review that's happening at the moment. And we cannot state enough how upsetting and triggering this topic can be for people. So please, please, please just mind yourself. If you need to step away and come back, it's going to be recorded. You know, that's all absolutely fine. The reality is that each of us will have some sort of experience or knowledge of self-harm or suicide. So the main thing is to mind yourselves in all of this, and hopefully we'll be able to bring you a bit of hope and signpost some of the good things that are happening. So that's just a reminder of some of the support slides that are there. So we'll go on to the next one, which is around the numbers and the context for suicide and self-harm prevention in Ireland. So we often hear about the numbers of people, you know, around 400, 500 people die by suicide in Ireland every year. But what we hear about less is that almost 10,000 people can present to hospitals and emergency departments as a result of self-harm and suicide ideation. And that's a huge, huge number. So again, we're very conscious that a lot of people will have experience in this area. Um, there is a Connecting for Life strategy, and that's our national suicide prevention strategy. And it runs out, so to speak, this year in 2024. It is being reviewed and it will be renewed. So there will be a new iteration of a national suicide prevention strategy next year, which is very, very welcome. So we did just a consultation piece this year to kind of try and get ahead of the issues that could be coming up, which is why we have a focus today on the deaf community and ISL, people using ISL. So the next slide there, Stephen, please. So in our consultation process, we have 86 member organizations, as Philip said, 9 of those who work specifically in suicide prevention did take part in the consultation process. And we also had an open public consultation online where we had people with lived experience come to talk to us. So in our final submission, which will be updating, I suppose, next year, there's 20 recommendations across 9 of the key priority areas. Now, these slides will be made available to you after the webinar, so don't worry about taking notes. But just to say there, you know, we've talked about things like aligning Connecting for Life with the mental health strategy, sharing the vision, which runs until 2030. Within sharing the vision, there are priority groups such as ethnic minorities, people, LGBTQI plus people, women, and others. And we have said that there should be a focus on those priority areas in Connecting for Life as well. We want there to be an open, accessible public consultation when the time comes in the new year. And we've focused as well on the importance of postvention, and you'll hear a little bit more about that later on from one of our other presenters. The big thing is the social determinants of health and how your socioeconomic status, your housing, your community, your supports can impact on your physical and mental health. There's obviously a focus on eating disorders and the high mortality rate for people with eating disorders. The crisis resolution model, like the Solace Cafes, which are a really great initiative. SCAN nurses, which are suicide crisis assessment nurses. We've also included in our recommendations funding for ISL interpreters, so for Irish Sign Language interpreters. The focus on neurodiversity. And of course, we can't have all of these ideas without them putting money behind the implementation plan. We want a fully costed implementation plan to be rolled out. So we'll go on to the next slide. So I just have to say as well, Susanna or Julia and Stephen did these slides and pulled all of this together and did the work on it. So you'll see here the spotlight is around the delay in reporting. Suicides have to go through the coroner's court, and there can be kind of a 2-year delay before we get data on any one year around the number of suicides. There's a whole piece around how suicides are classified and whether in a coroner's court, whether they will actually find that the death was due to suicide, depending on whether it reaches this legal term of beyond a reasonable doubt. So we know that the true rates of self-harm and suicide are much higher than reported. Thank you, Stephen. And you'll see here where the beyond reasonable doubt way that is worked on at the moment versus the balance of probabilities shows that it's a really high barrier, it's a really high piece that has to be met for a coroner to find that the reason for the death was suicide. It's actually rooted in the historic criminalization of suicide. Suicide was only decriminalized in 1993, like very, very recently. The fact that we're even having this coalition conversation today on this topic is really, really important, because we have to keep talking about this. The beyond reasonable doubt can contribute to stigma, and it does mean we don't have an accurate reflection of how many people are dying by suicide in Ireland every year. Whereas with the balance of probabilities, which is aligned with Northern Ireland and the UK, it means there's more accurate data. It's more aligned with dying by suicide and the decriminalisation of suicide. And one of our member organisations, HUG, have done some work on this, and they suggest that the true rate of suicide in Ireland is probably 20 to 25 times higher than currently reported. And on the next slide, please, Stephen. And I think the issue with us not having accurate data is then we can't have the right services that people need. We can't have the sufficient early intervention and prevention services that people need, the bereavement support, postvention, all of the interventions, the facilities of the scan nurses and solace cafes. If we're not working off accurate data across the country, across the island of Ireland, then how do we know what the real need is? So there, I mentioned that almost 10,000 individuals. That has been over 12,500 times, which means that a number of individuals may have presented to emergency departments a number of times. And that there could be more than over 50,000 additional kind of hidden self-harm episodes where people are not presenting to an emergency department. So the 12,661 times are those times where the attempt has been serious enough that the person has had to either be brought to an emergency department or has gone in and needed some sort of medical intervention. We're very lucky in Ireland that we have a National Office for Suicide Prevention, and we also have a National Self-Harm Registry, and it's an absolute wealth of information. And again, the reason why we are doing, making progress in this area is because we have been capturing data for a while. It would be great to expand on the data that's collected, but the registry is a really, really, it's a wealth of information. And just the next slide then, please, Stephen. So again, focusing on the data and reporting, because we're going to hear more in our next presentations around where we're going to hear about Northern Ireland. We're going to hear about some of our member organisations that provide services directly to people with self-experience of suicide ideation or self-harm family members. So this is kind of focusing on something that has come up quite a bit around the improved data and reporting, and something that we're hoping to work further on next year around how we move from this beyond reasonable doubt to the civil standard of the balance of probabilities, and that there is improved demographic data collection. We know that members of the traveller community have really high rates of self-harm and suicide, but again, we need to see that in the registry. We need to have the data so that we can use that as a tool to make sure we're improving everything for everyone that needs it. So again, I'm just going to say, I know this is a really heavy topic. I'm really delighted to introduce Professor Siobhan O'Neill, who is the mental health champion in Northern Ireland. And I think it's a really important perspective for us to look to the north and how things are working there. Some of our members, for example, the Samaritans, are an all-island charity. So they also provide services in Northern Ireland. So I'm going to hand out, I'll be quiet now. Siobhan, just a reminder to speak slowly and clearly for the interpreters. And also I'm going to be really strict on the time. So I'll pop on and give you a 2-minute warning. I'm also very impressed that I managed to stop myself at 11:15. Everyone who knows me will know that that's rare. So thank you very much, Siobhan. Looking forward to hearing you.
Hello, can everybody hear me? I can't see myself at all. Is it working? Yeah.
Yeah, we can hear you, and I think you'll be spotlighted just now in a second. Stephen is probably just switching the spotlights, but we can hear you.
Okay, thank you so much. So I'm going to speak for about 15 minutes on the situation in Northern Ireland, and I start my video. There we go. Thank you. You should be spotlighted soon. You should see. There we are. Hello, everybody. Hi. So I'm going to talk about the situation in Northern Ireland, and some of my work as mental health champion and how it relates to suicide. Um, I became a mental health champion in 2020. It was something that came out of our agreement, the New Decade, New Approach agreement, that got the government up and back again last time it fell. And then there was a pandemic. But in that agreement, New Decade, NDNA, New Decade, New Approach, there was a recognition of the need to tackle mental health, of the need for a 10-year mental health strategy, and they put in a mental health plan, which included a mental health champion. So prior to that, though, I've been working for 20 years in Ulster University back in 2000. I started working there, and over the years, I've been involved in lots of mental health research and more recently, suicide research and suicide prevention. So that was one of the reasons, I suppose, why I was asked to do this role initially and then appointed eventually. So I'm going to talk a wee bit about figures. I don't have this in the slides, but one of the things I'm asked a lot is what are the rates of suicide in Northern Ireland? So if we could just flick back a wee second, is that okay? Thank you. um, so our rates of suicide, one of the things that had been said, and I had said it, is that we were 25% higher than the other UK regions. And that was the case for a few years. However, we have been classifying accidental deaths and overdoses as suicide, so particularly overdoses since 2015. So our data had to be looked at again, way back from 2015 to 2020. And some of those cases were taken out. And it turns out that our rates of suicide in the north are similar to other UK regions. Some years we are above Scotland, one or two per 100,000, and some years we're below. We're usually above England a bit, but that thing of us being 25% higher is no longer accurate. It's no longer accurate to say that. We use we use in all probability as our metric, and actually UK have changed their recording classification standards to match that, and that led to a slight increase in the English rate per 100,000. So when we use the standards that you apply in the south beyond all reasonable doubt, and this exercise was undertaken a couple of years ago in 2022, they looked at the 2019 figures, and it found that our rates, when that standard was used, were about 12.1 per 100,000 compared to your figure of 8.2. So we're still a bit above the Republic of Ireland, basically, when we look at how this is measured. So the rates are too high, and every death is a preventable death. That's what I believe, although it's never an individual's, one person's fault, and one person could have prevented it. But generally, as a society, we can work together to prevent suicides and to provide proper care, crisis care for people when they're feeling suicidal. And we now know what that looks like. So we need to be doing that. So the data capture is really important. Northern Ireland are part of the All Ireland Self-Harm Registry, which is a really important initiative, and that's paid for through our money for our suicide prevention strategy, and that needs to continue. But there's much more we could be doing across the island, and we can talk about that maybe later. So let me go now to the next slide. Thank you. So when I started working in this back in 2000, I studied the impact of the troubles and the conflict on mental health and suicide in Northern Ireland. And I would be making the argument that it's still very much relevant today. So in 2005 to 2008, in our survey, which was a worldwide survey, and we did the Northern Ireland version of the World Mental Health Surveys. I hope I'm not talking too fast. Being from the north, sorry. But anyway, then we found that 40%, 4 in 10 of our population had a conflict-related trauma, and really high numbers saw someone killed or seriously injured, 18% there. We had nearly 4 in 10 met the criteria for a mental illness. Some of that was mild, obviously, but that's really shockingly high. And 1 in 5 had a mood disorder, and we had the highest rates of PTSD of all of the countries involved in that research program. So that was 20 years ago, nearly 20 years ago. And those people who were alive then, many of them are parents and grandparents. We have a whole new generation of young people with high suicide rates continuing, and there's lots of theories about this. But my argument is that transgenerational trauma is very important. But we did a survey last year. If we cut to the next slide there, 2023, as mental health champion, I asked the question just in the Northern Ireland Life and Times survey, and we found that 29, nearly 30%, nearly 3 in 10 said that the conflict continued to impact on their mental health. There were more males than females. Now, the Victims Commissioner did a survey, and they found 1 in 5 were saying this, 21%. So our survey, more people were likely to report this, and I don't know why that is. But even if it is 1 in 5 or somewhere between 1 in 5 and 3 in 10, that's still really high. And there's features of the conflict and trauma exposure that are related to suicide and suicide prevention and mental health generally. People who were victims or survivors of the conflict were more likely to have really poor mental health, and they waited longer for services as well, probably because of the more complex nature of their needs. But this is still a live issue in our population. Can I get the next slide there? And I'm one of those people. This is a slide from my village, close village called Claudy. And the Claudy bombing happened just a couple of years before I was born. And my mum had a shop in Claudy. And so just on that main street, further down, just past, if you can think, just going into the distance where that wee sign is for the car park, just a few doors down, that was where my mum was when the first bomb went off up the street. And she escaped, she left before the bomb and the car outside her shop went off. So I used to think that this hadn't impacted me, but I realise now, of course, that it has impacted every aspect of my life and who I am and what I do. And I wouldn't maybe perhaps even be here if my mum hadn't escaped that. And the person who interviewed me around all of this stuff was Lyra McKee, who was shot herself whilst witnessing the riot in Derry. And Lyra was the first to make that argument and to draw the parallels together and realise that there were more people killed more people died since the signing of the Good Friday Agreement by suicide than were killed in the whole period of the Troubles. So that's very important. Suicide is a significant issue in our society. It's taken as many lives, more lives than the Troubles, and it needs to be addressed, and it's linked to the Troubles too. So next slide, please. So the link is around this idea of transgenerational trauma. So the generation who hasn't been affected by the Troubles, those that are below my age, 50 and below, wouldn't have that much experience of the Troubles, but they were parented by people who were exposed to the Troubles. And we know that trauma impacts attachment, hypervigilance that's associated with the flashbacks and nightmares and PTSD. And we had high rates of PTSD, but higher rates of just all of the other trauma symptoms, that impacts on attachment, and it impacts in a biological way as well. And we're understanding more about what that looks like, the impact of cortisol exposure in utero, the epigenetic impact, at a cellular level that's passed on in terms of stress reactivity. But particularly around attachment, the child's stress response is shaped by the parent and per attachment, and the features of PTSD, such as emotional numbing, hypervigilance, avoidance, withdrawal, that can lead to adversities for wee kids and wee babies, and changes their risk of poor mental health. And if you have a parent who's hypervigilant and there's violence in the society around us, then we know that does get transmitted, and children model that behaviour and manage stress by externalizing, by being violent. And of course, that's associated with suicide and social violence as well. So it's related to peace as well. Okay, next slide. So this is my cycle of transgenerational transmission of trauma, and we can move to the next slide. So we've got parental limitations, and there's attachment problems. The child can have difficulty then with their own emotional regulation. Next slide. There can be negative relationship and parenting styles, big proportions using alcohol to manage the impact of the troubles, childhood adversities, anxiety, depression, other disorders. Next one, adolescence hits, and we have a drug problem, a huge drug problem, and an even bigger alcohol problem in the north. We have the highest rates of alcohol-related deaths in the UK, poor life choices, and then maybe children are conceived and there's epigenetic transmission. So if we move through the cycle, thank you. So we have high rates of childhood adversities in Northern Ireland. They're actually mostly no higher than other places, with the exception of the parental mental health one. This is from a 2019 survey. 10.7% were reporting poor parental mental health, and that's related to their mental health. There's a direct line there. So next slide. 1 in 8 of our young people have a mood or anxiety disorder. 1 in 10 have conduct problems. 1 in 7 hyperactivity. Disordered eating, self-harm is 1 in 10. It's really high. It goes up to 1 in 5 in our student population, and 1 in 8 of our young people have thought about or attempted suicide. So that's way too high, and that needs to be addressed. And this is just a wee slide from my research showing that there's other data that links this to conflict exposure back from that Northern Ireland study of health and stress. Thanks. I don't really have time to explain it in detail. So if we look at suicidal behaviour in Northern Ireland through a trauma-informed lens, you'll see ACEs, childhood adversities and mental illness, deprivation and inequality. The rates can be up to 3 times higher. Some years it's 2, some years it's 3 in our most deprived areas. There is that habituation to pain and violence that you get, chronic stress and fear, mistrust of leaders, hopelessness, the divisions across our society mean that we carry a cognitive load, a stressor that I frankly feel that you don't have that when I go south. That there's a difference, Thanks. 2 minutes left. Okay, high rates of substance use, reduced connectedness as a result of the injustices of the peace process that are felt by certain communities. And that's still manifest, it's still very, very real. The dividends of peace haven't been experienced equally. And we have othering, hate crime, racism, homophobia. We have the highest rates of femicides, murder of women in Northern Ireland, albeit the numbers are low, but they're, when you look at the rate, it's higher than the other regions. And then, of course, we have the normalisation and unsafe reporting of suicidal behaviour. So we just flick past that one. That's me. I'm into everything, basically. Next slide. We have a mental health strategy, which includes suicide. It includes suicide prevention. And there's a suicide prevention strategy as well. Sorry, Pat, next slide. Just keep going. Next slide. Yeah, but we don't have enough funding for that strategy. Our Protect Life 2, our suicide prevention strategy, is up for review. And we're considering putting in things like specialist groups, neurodivergent communities. How do we deal with, how do we we deal with the increased risk, what should we do there? Or should we have special groups that are highlighted in our strategy? We didn't last time, but there's some strategies to include that, and others would argue that every death by suicide needs to be treated equally, regardless of the subgroup that you're a member of. So those are some slides around our Protect Life strategy. Interestingly, I want to end with this one. We have a program in our mental health services called Towards Zero Suicide, where we are sort of putting through a program of change. Yeah, this is it here. And I note in the South, you don't have this, but you do have quality improvement programs in mental health. We're calling it a zero suicide program. So I think that's an interesting thing that maybe you would want to look at. There's all sorts of arguments against using the phrase zero suicide, but also we recognise that zero should be the only target, particularly where you have a mental health service and safety plan and interventions, which really do work. So that's the components of that programme. So looking forward to the panel discussion later, and sorry that was a bit rushed at the end. Thanks for listening.
No, it was great, Siobhan, and I think that's the exact thing. Is we'll have some time in the panel discussion, and I think your presentation just really honed in on the importance of trauma-informed care, and that's something that we're all talking about. And your zero suicide, you will hear from Verona now with the No More Silence campaign as well from Pieta. So again, I'm going to be quiet and introduce the Interim National Services Manager in Pieta. We're delighted to have you with us this morning, Verona.
Thanks, Ber. And Siobhan, that was a fantastic presentation. It was very powerful. So thank you for sharing that. So my name is Verona Farrell. I'm the Interim National Services Manager with Pieta. I've also worked as a child and adolescent therapist with Pieta. So I suppose I've experience of the clients that are coming in. I've worked with adults and with children, and it really is profound, the work that Pieta do. You can go on to the next slide, please, Stephen. So just to tell you a little bit about Pieta and its services. So Pieta would work with people who are feeling suicidal, that are self-harming or have been bereaved by suicide. So we divide it up into 3 areas. We have prevention, intervention and postvention. So with prevention, it really is trying to support people with their own mental health and to give them as much kind of tools and resources. So it's education and awareness. So we're coming into schools and communities and we're running programs like the Resilience Academy and the Amber Flag program, and then raising awareness. You've all heard of Darkness into Light. It's a very unique kind of powerful event. It really gets the communities together. And we have the Know the Signs campaign then, which would be again highlighting the signs of suicide in the community. Intervention then, I think, is what people think about when they think about what Pieta do. It's the services that we offer. So someone comes in and they would have 12 sessions. So initially they have an assessment and then up to 12 free sessions. They can self-refer into Pieta. There's no need for a doctor referral or for anyone else. They could do it themselves. So when they come in for therapy, we work with a solution-focused model. We'd also use some CBT, giving them kind of tools, really trying to meet them where they're at. Like sometimes people will come in and they'll be really overwhelmed and flooding, and they'll just need that person-centered care. And, it is unique to every individual, but we do like to ensure that they have some tools that when they're leaving Pieta, that they have the resources and skills that, if they do start to slip or that suicidal ideation comes up again, that they can actually cope. We'd also work closely with other organizations then and make referrals. So in the likes of with young people, for example, when they're no longer suicidal, we would refer on to Jigsaw and things like that for further supports. We also have our 24-hour crisis helpline. So this is a fantastic resource to have. Anyone who's feeling suicidal can call this 24/7 all throughout the year, 365 days. Qualified therapists are there. It really is amazing to be able to offer that. And it's also fantastic for parents or, people that need support. Like it could be a loved one and they really don't know how to support the person in crisis. So you can call the crisis helpline and the therapist will be able to talk you through how to actually manage as well. So whether that be that they're coming into Pieta or we're referring to A&E or the doctor or whatever it would be, but we're offering support. Postvention then is our suicide bereavement liaison officers. So these do wonderful work. They would come in after someone has lost someone to suicide. And as you can imagine, this must be a horrific time in someone's life, and that they'll come in and they'll offer support, and it can be practical. It can just be around helping with I suppose even the funeral with the coroner's court, pieces like that, it can be then helping with the emotional side of things as well. And we refer them in then for bereavement counselling when they're ready. And when they come in for bereavement counselling, it's 30 free sessions with Pieta, and that would be for adults and children as well. You can go on to the next slide, please. Yeah, and again, this is just the clinical overview. So I think back one. Yeah, thank you. So just with our intervention services, then you can see in 2023, we had over 5,000 clients and we offered over 40,000 free therapy sessions. So it starts with the 1 assessment and the 12 sessions, and they're an hour long. So 40% of the clients that we see are actually under 18, and there's been a noticeable trend there since COVID. Like there's been a big increase in the under 18s, including kind of under 12 clients as well. So Pieta has, been trying to offer kind of training for our staff as psychotherapists to train in the child and adolescent therapy or play therapy to be able to work with the younger clientele. So 60% of all clients are under 25. So again, that's a very young demographic, and more than 60% of all clients that are presenting are female. I have a little bit of information on that later as well. So you can go on, Stephen, thank you. So just with our crisis text and phone line to give you an idea of the impact that has. So like you can see the calls there over the last couple of years. To look at 2023, like over 40,000 calls, 75,000 texts, and you can see the notable increase in the text service. So this has been interesting because we've noticed like a real growth in the text communication, particularly with young people. So I suppose they really do prefer to to be anonymous and not have to actually maybe pick up the phone and be heard, that they find the texting that bit easier. And that would tie into how much social media is a part of their lives, really. And they'd be very much kind of involved with like Snapchat and TikTok and those platforms. So the text has certainly increased. You can move on. So the post-vention, then the suicide bereavement. So we have seen in 2023 over 889 clients, and with the free therapy for bereavement was over 9,000 clients. So again, it's the assessment with the 30 sessions, and again, they're all hour-long sessions. And the number of suicide bereavement clients grew by 30% between 2021 and 2023, and it continues to grow in 2024. So the suicide bereavement liaison officers, the people that will go out to the homes after a suicide, we are available in every county. It really is a service that we've noticed an increase in, and to be able to offer that support in the immediate impact of the stress and the shock is really needed. Yeah, so some key issues and trends. So I suppose just to look at kind of who's presenting to Pieta and like their clinical risk level, we do see that the majority of people who present, as you'd imagine, we're a crisis intervention service, so they are high risk. But you will also find that we do have medium risk and low risk clients. So we do work with those as well. I suppose it's really important to have the timely intervention of mental health support so that it's not really escalating to a further kind of crisis or a suicide in progress. So we would see them with lower risk as well. Yes. And then the age range, as you can see, majority are under 18. As I said, 60% are under 25. And that does allow for like a change in how we're working in Pieta, because we're working with families. We're having to offer further support to families as well. So it is changing. Yes. And that slide is just to show the actual age range. So I had an assessment last week with a 9-year-old. And that really can be very difficult, trying to ascertain, is a 9-year-old suicidal, explain suicide to a 9-year-old. And we, as I said, we do have play therapists that would work in a unique way with the under 18s, but you can see the average age is that wee bit older. It's kind of that 14 to 17. The 2 minutes, thanks. Okay, I may zoom on. So the gender then, as I said, it's mostly female, and 60% are female. So again, that's a profound statistic. We need to really reach the men, and I know the signs would have been aimed at trying to highlight that as well. Sorry, Stephen, you can go on again. So sustainability, just to note that Pieta is 85% funded from the public. It's people who do the fundraisers that, raise money, and only 15% comes from the government. So again, that wouldn't be a sustainable model of funding. Continue. So just what finally are no more silence, then you can go on to the next slide, Stephen. So our No More Silence campaign is very important. I suppose it's to really have those conversations about suicide and not to be afraid to have them. There still is a stigma around suicide, and people are, afraid to talk about it. There's shame around it. So our No More Silence campaign is sought to influence the public and the political narrative around suicide and self-harm. And I suppose just here today, just even to say, if you had any concerns about anyone, not to be afraid to ask them, like, are you having suicidal thoughts? And there are supports out there. Like you'll see today, there's numerous supports out there, and it's to, support that person then and getting the help that they need. So we really need to just continue those conversations. Thanks, Ber. I'm done, am I? Great.
I'm so sorry. I feel really bad for rushing people.
No, not at all. You're fine. I understand.
Yeah, and I think it's the thing of, I feel like today and this coalition conversations is kind of like a taster for the wider conversations that we can be having about suicide.
Absolutely.
And linking in with services, a bit of signposting, and hopefully people are learning about services that they didn't know existed previously. So I am really sorry for
That's okay, Ber.
rushing
No,
you.
thank you. That's great.
And what we can do as well is, I know you have an event coming up in December with DCU as well. Like we share those kind of links in our newsletters and things like that as well. So I will be encouraging people to sign up to our newsletters and follow us on socials, because we will promote the events that our member organizations are undertaking. And just to say as well, like I'm feeling quite upset at the moment. It's heavy, and it's all of those things. So just a reminder of the supports that are available. And again, if you feel the need that you want to step away and come back and watch the recording when it's available, we absolutely wouldn't take any offense from that at all. But at the same time, I think there are some really great conversations been had, and hopefully giving people that confidence that, one, that you're not alone, or that, two, that there are services and advice that you can get as a loved one as well. So I'm delighted now to hand over to Breed, and I'll note that I've taken 2 minutes of your time, Breed, don't worry.
Thank you.
Breed is the Eden manager in one of our member organisations, Suicide or Survive. So thank you so much, Breed.
Thank you, Ber, and a huge thank you to the two previous speakers. What amazing presentations, just wonderful to listen to. So my name is Breed O'Mara. I'm the Eden Programme Manager with Suicide or Survive. And who is Suicide or Survive? So it's a national mental health charity. It was founded back in 2003 by a lady called Caroline McGuigan, who had had her own experience of a very difficult period of mental ill health. And during that time, she made a serious suicide attempt, which she survived. And as a result of her experience, her lived experience, she, identified that there were significant gaps in the services, and she felt it was really important to do something about that. And she started the organisation Suicide or Survive. So I'm going to talk predominantly today about our flagship programme, which is the Eden programme, but just to mention that we also provide wellness workshops, supporters programs, workplace programs all around mental health. But what is the Eden programme? So the Eden programme is a programme that is aimed towards people over the age of 18 who have contemplated or attempted suicide. It's very much an educational programme, but there's a therapeutic component to it, and it runs over 26 weeks. So it would be a half day. If it was the face-to-face programme, it would be a half day once a week for 26 consecutive weeks. And when we do the online programme, we tend to do it in the evening time. It's a closed group and just 16 people. And the main purpose of the group is to help people to move away from suicide as their option of choice in the times of crisis. So really what we're trying to do is we're trying to encourage people to, monitor their own mental health, to develop skills, to be able to manage their mental health and to cope in different ways when crises happen, because, we all have difficulties in life. So we're not saying that coming on the Eden programme is going to take away the difficulties of life. What we're trying to do is we're trying to help people to be able to manage life a bit better when things, when we meet the ups and downs of life. And it's self-referred, so we don't need any referral from any doctor or therapist or anything. People can refer themselves. So it's been running since 2005. Currently, the 40th programme is running face-to-face. We're on week 20 at the we're on week 20 at the moment, And our 41st program is running online at the moment, and we're on week 2. We've just had week 3. The online format, like lots of online formats, started in 2022 during COVID, and we've been running it annually since. The Eden program is the only program of its kind internationally. There is a program similar to it that runs in New Zealand, but it doesn't run for the full, the length of time that the Eden program runs. You can continue on there, Stephen, please. Thank you. So a big thing about the Eden program is the structure of the day. So what we hear from participants is that coming to the program every week for 26 weeks is really helpful, because it's almost like a grounding time in their week. And then when they come, we hold a format so that when people are coming, they know, well, this is what's going to happen. So there's a predictability about it, even though every week we address something different. So we always start with the check-in. How are you today? How are you feeling? Is there anything that you've learned previous weeks that you put into practice? If there is, how's that going? We always do a support document. And the idea of the support document is so that people over the 26 weeks get used to the idea of, how can I support myself? Today I will support myself by, or today I will, help myself by doing A, B, or C. And when the program starts in weeks 1 and 2, that might be just, how can I support myself to stay in the room until the session is over? Whereas towards the end of the program, we'd be looking at, well, how can I support myself during the week or further on? Or how can I support myself around particular things that are coming up for me? We always have a coffee break so that people have a chance to speak to each other and socialize and develop relationship outside of the program. And then we do the educational session. So each week there's a different educational session. So we cover everything from recovery, anxiety, depression, suicide. We address suicide very, very much, very clearly, very head on. We talk about boundaries. We talk about building natural supports. We talk about relationships and relationship management, emotions and emotional awareness, conflict. So we cover a whole range of subjects over the 26 weeks. They build on each other, so that there's sometimes we're revisiting, but with a different focus, because they'll already have done a module early in the program, and we might revisit it in a different way with other skills and tools learned in the meantime. And then we always do a checkout. How are you now at the end of the session? Is there anything you can take away from today? And we offer support calls between sessions if required. So we're not an on-call service. What we do is we ask the participants to maybe send us a text, and we will arrange an opportunity for you to talk to us at a time that suits both. So you can move on, Stephen, if that's okay. Thank you. So we've had the program externally evaluated on a number of occasions. DCU have done a few research pieces for us, and we currently have our online program being researched by University College Cork. So the evaluation findings so far have said the program is effective, and the approach of the facilitators is key to this. And I'm going to talk a little bit more about the facilitators in a minute. The change for the participants is supported by the clear structures that we have in Eden, by the content of the program, which I've mentioned some of the modules that we would do, and the ethos, which I'm going to talk a little bit more about. And the essence of the program is held because we have very good support structures and governance around the program, and supports for the facilitators, which is really important. And the research also very clearly identified that we're consistent with Connecting for Life and with Framework for Recovery and Government Policy. Thank you, Stephen. We move on. The research also showed what the benefits were to the participants. So benefits to their daily lives, to just how they, get through each day. An increased sense of hope, which we know is hugely closely linked to suicide. An increased belief in themselves and a future, and a change in their relationship with suicide, and that they are more motivated to change. And again, it highlighted the positive impact of the facilitators. We bring in guest speakers as well, which I didn't mention. Sometimes we would bring people in who have previously done Eden, and they'd come in and maybe talk about their personal testimony, how Eden impacted them, the difference it's made in their lives. And it's not, coming in saying, oh, my life has been wonderful since, because that's not life. But they're coming in and they're saying the difference Eden has made to them in terms of how they're managing their lives. That's hugely impactful for people on the program at the moment. So we can move on, Stephen. This is just, we use the core 34 outcome measure, and we use it at the beginning, the middle, and the end of the program. So just very briefly, because I don't have long to speak, you can see down at the bottom there, our suicide and self-harm scores improve by in the region of between 45 and 50% across the board. So if you just move on to the next one as well, Stephen, you'll see that a Kildare one there was 88%, which was a huge improvement. But our normal improvement would be kind of around the 50% mark. Can we just move on again, Stephen, please? So the philosophy and the ethos is really, it's fundamental to Eden. And this is about meeting people where they're at and about acknowledging that everybody has the capacity to grow, everybody. This is very much about a program around, choice and helping people to recognize that they have choice. And when they have choice, that then they can take personal responsibility for everything they do. We have a real focus on equality. So even though there are facilitators facilitating the program, there's very much an equality within the room, because the people in the room have the lived experience, and they are the experts in their own lives. Non-judgmental is very important, meeting people where they're at, allowing people to bring whatever they need to bring into the room. And then obviously dignity and respect goes without saying, but it's hugely important. Can we move on again? Because I'm just conscious I only have 2 minutes left. Thanks, Stephen. There's a very strong structure and governance. So our two facilitators, we have two facilitators, and one of them coordinates each program. They all come from mental health backgrounds. So they're either psychotherapists, psychiatric nurses, psychologists. We train them in Eden to facilitate the program. And then as Eden manager, I would go and sit in on the program at least every 6 weeks to monitor the integrity of the program. The facilitators produce a written debrief at the end that they give to me and the CEO. We also have external supervision on a very regular basis, and we do CPD as well. We'll just move on again, Stephen. I'm flying through this now. These are some quotes from people who have done the program, but I would really like to read this poem that a participant wrote last year, actually earlier this year, 2024, who finished the program earlier this year, and I just think it really sums up Eden. So it goes, Eden program, no, it's not for me, but I'll put my name down, and sure what will be will be. First day jitters, my legs feel like fried fritters. These people won't understand. They won't be there to lend me a hand. The morning would come, decision to be made. Do I lay here in bed or go to the course to tell them I wish I was dead? Shame and fear that suicide can bring, but no safe place to share our feelings. That's the real sin. No judgment here. We've walked the same way. Your feelings are valid. That's all we can say. So Eden, what have I learned? What are these emotions and why do they burn? My head full of thoughts spinning my head. How do I stop these thoughts that push me towards dead? Where are the answers that I cannot see? Well, let me tell you, it's no secret. It's already inside of me. So look inside and look real deep and get to know yourself and wake from your sleep. The new you is coming, so embrace the change. With Eden's help, life will feel less strange. An open blanket that wraps our heart. Empathy and self-awareness is our gift from them, and that's just the start. Now my toolbox is full from all I could bring from this magical course called Eden. I'm all stocked up for my journey ahead, no longer wishing I could choose suicide instead. Thank you.
I think I'm going to speak for everyone here, Breed, when I just say, wow.
I know.
That was very, very, very powerful and beautiful.
It's so powerful. And I think I could talk for an hour and I would never capture that. And I think that's why it's so important to use it. Really important. Yeah.
Absolutely. I'm kind of glad my camera was off as well. I was having a moment, as I'm sure many people who are listening in, and imagine if I had cut you off halfway through, been like, sorry, your 2 minutes are up. So I was like, no, that is really, really beautiful, and thank you so much. And I think the comments that you have there as well on the slide of people's experiences. Like you mentioned, you know, people are the experts in their own experience,
Yeah.
and that's so important.
It is, yeah.
Yeah, it really, really
And
is.
I think a really important part of Eden as well is that people are actually getting to share a space with other people who are having similar thoughts and feelings,
Yeah.
and like that's just so valuable, so
Yeah,
valuable.
and in the poem as well, the words like shame, and I think we talk about stigma so much, but self-stigma is a huge, huge, huge
It is,
thing for
yeah.
people with experience of mental health difficulties. I'm looking forward to coming back to you now in the panel. We have our
Okay.
last presentation now from Elaine Grehan, as the advocacy manager with the Irish Deaf Society. So hopefully some of you know Elaine, but just to say, so Elaine will be signing, and Willie, our ISL interpreter, will be voicing Elaine's presentation. So just to flag, if anyone isn't watching the screen and they're surprised when they hear a male voice, but it's Elaine's presentation. But never mind the fact that it's a male's voice. He's from Kerry, so it's a male's voice with a Kerry accent, and Elaine's presentation, and Elaine's from Longford. So I'm going to hand over to Elaine now, and then we'll come back out and we'll have everyone for the panel discussion. So thank you so much to Elaine and Willie.
Hello. So I want to thank Mental Health Reform for inviting me to present today. And today I want to have a discussion about the importance of the mental health issue within the deaf community. We have barriers and challenges. Unfortunately, we don't have any clear statistics on the numbers of deaf people who have had suicidal ideology and so on. But I know that a lot of deaf people, we've lost a lot of deaf people to suicide. And sometimes suicide has been confirmed. There's been some kind of reasonable doubt in relation to it as well. But then other times we've said, actually, we do think it has happened, but it's unsure. But we need to ensure we have mental health support for deaf people. I want to encourage you all to think about how can we work together to ensure deaf people have access to mental health services that they need. Deaf people face barriers and they have mental health challenges, and they can, in a range of areas: communication barriers, social isolation, stigma, trauma, insufficient access to mental health resources. And next slide, please. Oh, I have a slide here. Great. Oh, you can go back, actually. Great. Thank you. Will you go back maybe one more again? Another one? Good. Great. Deaf people, they have faced a lot of issues. So what has really happened? I don't know if you're aware within the deaf community, but I'd like to share some real life experiences of you. 90% of deaf children are born to hearing parents, and the majority of these hearing parents don't have sign language. And this can have an impact on communication and communication development, and it can lead to language deprivation. 8% of deaf adults have not acquired full fluency within English. So ISL is a critical thing for their access to communication. Sign language was rejected within schools, so that has had an impact on our cultural and linguistic oppression. So deaf people were left without any access to full communication or education. And can you imagine that it was an oral method that was in place? It forced people to learn how to speak and to listen. And deaf people, for example, were being forced to try and become a hearing person, try and fit into the hearing world. And that put a heavy burden, and there was a consequence under stress, anxiety, and trauma, and so on. And currently, ISL within the classroom, it's not compulsory within schools. In schools for the deaf, it's not in place. But we know that within education, every child, their first and preferred language is important to ensure that they have access to their own development. And without sign language within their education, deaf children are facing huge barriers to communication, society, integration, and mental health, and so on. And it can lead to language deprivation and limited opportunities thereafter. There's only a small percentage of deaf people who've gone on to further education like college, or who have gone through a full range of career options. It's had an impact on their social and life skills and their mental health. and this is due to system ignorance. Many children grow up, they go either as day pupils or residential pupils, but they've experienced abuse from peers or from staff. So when they left school, they're relieved, you would imagine, that they can now go on to the new world, but no, because when they meet other people within the deaf community, they might meet their bullies within the community, where a hearing person might move on and anything happened to them in the past is gone, but a deaf person could be in the same community where they experienced their abuse. And they want access to community, but it's not a simple process for them then. So there are challenges for deaf people. They feel they've been robbed of certain environments. They have to face their abuser or their bully. Then they might choose to avoid the bully, and they will choose to live more rurally and isolated. So there's a range of reports, including the Murphy report, and then the inquiry into abuse. Those reports are very important to help us understand of the suffering that children experience within residential schools and even as day pupils. And deaf children were an easy target because there was a communication breakdown there. Guards also didn't have sign language, so it was very hard for deaf people to go into the guards to report things. Then without support, without crisis support interventions, even if someone goes to prison, there isn't support within prisons. If there's a 12-step program, there isn't support there. Mental health services, there are no targeted for the deaf community here in Ireland. So deaf people face barriers, and we need culturally appropriate services. We may not have ISL interpreters in place. The professionals may not understand about deaf culture, and so on. And without access, it means that there's an increase in mental health issues within the deaf community. And it's important that we target to see improvements within mental health services for deaf people to ensure their needs are met. Without ISL, Irish Sign Language, and without deaf-specific services, especially in care homes like nursing homes, it can have an impact on older people as well. We need people to be able to link in with sign language users so that they don't become isolated and impact their mental health. Within the mainstream services, a deaf person may not get their supports and they can feel left out, and that can exacerbate their mental health issues. And so people can feel excluded. They can feel that they're not involved in their local community. They may have limited opportunities for them to get involved in sports or other hearing-related activities. And sporting activities are very important for mental health, but deaf people may not be able to get involved in sporting activities even on a local level. Many deaf clubs have now closed down, and this is where deaf people had their own space to communicate in sign language, where they got that support. Where now with deaf clubs closing down, there's more sense of isolation. And there's a challenge. People are discriminated in school, in employment, in social activities, and that can impact on them and create further stress. And the issues can impact them on a long-term basis with their mental health. So there's a limit of mental health resources that deaf people are not getting sufficient support here in Ireland, and that's needed. Deaf people have struggled with their own sense of identity. Are they deaf? Are they hearing? They're involved in the hearing world, but they may feel alienated from that as well. Next slide, please. Yeah, so next slide, thank you. So positive steps going forward, we now we wanted to kind of create some very important things. And one of the things that we wanted to secure was the ISL Act. This now is officially recognised Irish Sign Language, which means deaf people now have better access to services and they can use ISL within education, mental health services, and so on. So to have the Act now is amazing. We have the Belfast Statement on Mental Health and Deafness, and this is a best practice document for mental health care for deaf people, and to help improve the understanding and supports and to ensure their needs are met. We have an ISL Charter, which is promoting kind of guidance on to ensure that people know what deaf people require in terms of access, to promote the use of ISL, and to promote the deaf people's rights within community. We have the UNCRPD, which was, it's a world recognition now on the rights of deaf people and disabled people. And this, we can now advocate to ensure people have access to services and that they're fully inclusive and that their voices are heard. So it's important that we have these. And it means that people feel that they can network and interact with other services and so on. Sorry, I have to take some water here. My mouth was dry. It's as if I'm actually speaking verbally, but anyway. So it's important that we network with public services, and this is key to having to increase understanding and knowledge, and to ensure then that the right help and supports are in place, and to make things that are better for people. And we need to ensure we have that. Linking in with mental health reform is great. And we are a disabled persons organisation as well. We are one of the members of the DPO network. And it's important that you consult with disabled people, and this is something that deaf people want as well. Next slide, please. So we need to ensure that we have specific services for deaf people who have mental health issues, and to improve access, and to ensure they're culturally appropriate to deaf people, and that they can interact with mental health services. And then we'll have correct data then for deaf people as well. We need to have mental health specialists who have an understanding of sign language and the deaf community and deaf culture and so on. In the UK, they have 3 specialist services that are based in London, Birmingham, and the Greater Manchester area. They have deaf professionals who are qualified in mental health issues. They have social workers, nurses, they have psychiatrists, psychologists, OTs, ward managers, and so on. And they can identify, they have deaf awareness, they know of the importance of that. There's good deaf mental health services now, which is great for deaf people. If a deaf person comes in, they can come into a sign language environment, which is very, very positive. And there is deaf gain there. There's cultural and linguistic competency there. And people can integrate with mental health services, and that can help them to recover and feel well and recover from mental health. There's a lesser dependency on sign language interpreters as a result, because the professionals are fluent signers. All the professionals have fluent sign language. And they have also established a lot more deaf adult mental health supports, and they're establishing deaf CAMs as well for young children and adolescents for mental health as well. So we want to see the same thing happen here also. Next page, please. So right now within Ireland, we don't have access to mental health services in Ireland for deaf people. So it's important that we create specialist supports and resources that are unique for deaf people's needs. Research has shown from a deaf perspectives that hearing people using sign language, you are now showing your respect and your value. It can give a sense of confidence to deaf people when they see that you are using sign language. And we need to use sign language in mental health care. It can help us build trust and improve results from these supports as well. And sign language is key. Sign language is key, and it's very clear. Communication is key to access mental health services, and this will make it much easier for deaf people to access and then gain full access to support services. So to conclude, I think do I have a last slide? But anyway, to conclude, moving forward, we need to create change. We need to work together, and it's important that we improve mental health services for deaf people. We need to raise awareness. We need to have advocacy and advocate for a specialist service, and to ensure people have access through sign language across all services, and so that we can all work together for the future, so that deaf people can receive the care they deserve. And thank you all for your attention. And I think if we work together, we can then create change.
Brilliant. Thank you so much, Elaine. It's really, I've gone through such a range of emotions through this coalition conversation. So I'm really looking forward to our panel discussion. I know we're a little bit kind of behind time, but I think that that's okay, because the presentations were all really, really important to see. So Stephen, working his magic in the background, has brought Siobhan, Breed, Elaine, and I think Verona is hopefully there as well. Yeah, brilliant. And we have our ISL interpreters still with us. So you'll see there, we have the hashtag coalition conversations for any of you that are tweeting or sharing about this on socials, and also hashtag suicide prevention. So what I'm going to do, sorry, I'm just checking on the Q&A, and actually, yes, so someone is just saying, well done to Elaine, it was brilliant. And I think your point, someone else actually asked earlier about accessibility of services. She was asking, or they were asking specifically around Pieta, but I think it's a really important point that the government need to make funding for accessibility and reasonable accommodations available to services so that ISL is included, you know, that reasonable accommodations are made, and other interpreters, languages, all of the kind of, imagine universal design. Imagine if we had universal design, that's the dream. But anyway, Verona, I'm going to come to you first, because I'm sure listeners were really touched by when you spoke about the children and young people that are accessing services. So if you can just very briefly talk to us a little bit about the challenges and complexities in supporting children and young people and their parents. And then also if you can just kind of let us know if there's any accessibility things that are coming down the line in Pieta to help make services as accessible as possible.
Yes, of course. So just in relation to the children and adolescents, like it can be quite complex. And it is a system that you're working with. You know, we can't just work with the child in isolation and then forget about the family, because you could, like I've had sessions where you'd have a child for 50 minutes and you think you've done some really good work, and the parent would come in for the last 10 extremely anxious. And we know that children mirror what they see. So it's really, really important that we're offering that psychoeducation to the parent as well, that they understand and that they can get support, because it's very stressful for a parent too. So we do offer key person support in Pieta. So what it is, it's 4 sessions just for a parent. So it would be around knowing the signs of suicide, knowing about self-harm and how to support with self-harm, just even the psychoeducation that because your child's self-harming, it doesn't necessarily mean they're going to die by suicide or they're feeling suicidal or anything like that. So it's just explaining, you know, that self-harm may be emotional regulation and understanding around that. And we also have a session on the adolescent brain, which I think is really important, because, you know, if they're not in the prefrontal cortex and they're not rational, there's no point in having any conversations with a teenager. And I think when parents even just have that comprehension, they're like, oh, do you know what? They're not okay to talk now. We're not to bombard them when they get into the car after school, you know, that we give them some space and pieces like that. And finally, we do a session on self-care, which is really important as well, that they can look after themselves with all of this as well. I think one of the other difficulties we see in Pieta is our wait lists with young people. So we do have a wait list at the moment, and that can be difficult. And then in relation to accessibility, I know, as you said, in an ideal world, we would have everything, but like all of our centres will be like wheelchair accessible. In relation to interpreters, we would accommodate with different, with the deaf community, but also with any different nationalities. We would have interpreters come in for sessions, whether that be in person or online. So we do accommodate things like that as well. And I suppose I'd really love to see us all kind of working together to see what changes that we could make, and even those referral pathways. Like today, it's fantastic to hear about the others, you know, and I'll definitely be referring that Eden program sound amazing, Breed. So thank you for that.
Thanks so much, Verona. And I think that's, again, it's part of the thing of getting information out there of the services that are available. Just on the accessibility piece, is there, because I know for ourselves in mental health reform, you know, it's a plan to make our resources on our website and things like that more accessible. But I know we talk about it in the community and voluntary sector, but sometimes the funding is the barrier there.
Well, absolutely. Funding is absolutely a barrier for Pieta, but I suppose what we are doing is we've actually had to close a couple of our centres this year. And again, that's down to costs of rents and different pieces. But what we are doing is opening outreaches, which is like smaller, and they're kind of going into HSE buildings and pieces like that. And the costs are lesser, but we do still have a presence in the community. Do you know what I mean? So that's making us more accessible. Perhaps in counties like Louth, for example, is one that we've recently, you know, and Meath is another one that we're looking at the moment. So we are becoming, but again, they're not big centres. It's small kind of one outreaches, but our presence is very much there. And we have outreaches as well that accommodate for the ages 12 to 25, and they are HSE funded, which is fantastic as well, because that's where we can see the need is, you know. But again, we need more funding. Like, it'd be fabulous to have more of those services available.
Yeah. And I think I keep going on about the 9 million for the phone pouches at the moment, but hearing you say that for young people, the text support is becoming increasingly popular. I think, again, this is why we need to consult with young people, because for some young people, maybe when they're in school, accessing the online mental health supports or tech support is the only time safe space that they have to access the
Absolutely.
support. So I think there's a much more nuanced discussion needed because there are so many online mental health supports and services, and we not to negate the harm that online bullying and things like that does,
Yes,
but in the same vein there are some really accessible and positive services. Breed,
absolutely. Thank you.
sorry, thanks so much, Rona. Breed, I'm going to come to you next, because we're mentioning a little bit about kind of the supporting family members, and to build on what Verona had said around the courses for the parents and understanding the adolescent brain. But you have a supporters program as well. So can you just tell us a little bit about that as well, please?
Yeah, sure. So the supporters program grew out of Eden, actually. So it came about because people who were participating in the Eden program were saying that they felt that, you know, it would be really helpful if some of their family members had some more support and some more understanding of mental illness and how it presents. So as a result, we created the supporters program, which has proven to be really, really successful. So basically what the supporters program is, it's a program to support people who are supporting a loved one with, you know, any mental health difficulty. So it doesn't have to be around suicide. It can be anybody who's struggling with a mental health difficulty. And there's a couple of components to it. So there's a big focus on self-care, as you can imagine, because, you know, looking after the person, the carer needs to be cared for as well, and really focusing on how can they look after themselves. And then we do a good bit on connecting. So, you know, how can they connect in a more helpful way with their loved one who is struggling. So we would do a lot about listening, and, you know, listening more effectively, and being able to have good conversation, and being able to support somebody who's in distress. So that would be a big section of it. Another big section of it is about empowering. So the empowering part is about how can I empower my loved one to maybe help themselves, or, you know, look after themselves better, or instead of, because, you know, the way sometimes when we're in a caring role, we nearly take things away. And what we're trying to do is actually give back and give people back their power. So that's a really important part of the supporters program. Another part then is what we call supporting movement, and that's about, you know, building hope. Maybe, you know, looking at meaning and purpose, which are so fundamental to us all, and how important that is for somebody who's struggling with their mental health. Encouraging, you know, encouraging supporters to value small steps, or to encourage small steps. It doesn't have to be something huge, that sometimes just taking small steps can make such a difference to somebody whose mental health is compromised in any way. And then we do a lot of kind of talking about supports, you know, so natural supports that are in the community, or other supports that are available, even listening to the other speakers today, and signposting people so that they can avail of what's out there, what's available.
Brilliant. And a question actually just came in there on the Q&A, specifically for yourself, Breed, around do you do any of the, you know, the recovery focused, like the RAP program, so the Wellness Recovery Action Plan, is that anywhere in your services?
Yeah, so we had been delivering RAP up to very recently, but RAP is so widely available now that we have actually started to focus our attention on areas that aren't being covered elsewhere, like Eden, like the supporters program, wellness workshops. So we have actually just taken a step away from that, simply because it's so readily available. You know,
Yeah,
a lot of places are delivering it now.
I think, and that's such a good point, and it's such it's such an important reason of why we have these coalition conversations, so that we can all learn from each other, and we don't want to have loads of duplication of services and then gaps where things aren't coming through. I'm going to come to Siobhan next, if that's okay. And yeah, again, Siobhan, fascinating presentation. It really, really is, and I think we know that, like, certainly my generation of pals have family members, you know, parents from the north who moved down to the Republic during the troubles and all of that kind of stuff. And then we also have intergenerational trauma from the institutional abuse that we've had in the Republic. But what opportunities do you see for cross-border services or supports or collaboration? Like what would you like to see kind of for the cross-border piece?
So at the minute, there's the Samaritans is available obviously across both jurisdictions, but health and social care in Northern Ireland is separate obviously from healthcare in the south. And in terms of services, I don't think there's any other services that would work across the border. Although we have been having conversations with various different groups who are interested in establishing in the north, but we have a strong community voluntary sector here and services that are funded under our Protect Life to suicide prevention strategy that would deliver suicide prevention care and interventions in Northern Ireland. So in terms of services, there's very little real cross-border work, and because that's healthcare, I suppose. Where we do have a lot more opportunities, I think, is in terms of research. So I'm working at the minute leading a mental health package as part of a Shared Island Unit funded Atlantic Futures programme. We're working with NUI Galway to look at digital mental health interventions for young people specifically, and to do that engagement work to find out what young people want in terms of digital interventions, not specifically for suicide prevention. I suppose it's very much about supporting other interventions and earlier interventions digitally, but there's some strong evidence that some of these packages can be really useful. So both our strategies in the north and south are quite similar, actually, our mental health strategies and the suicide prevention strategies, so I would always be looking for alignments there to think about what we could do together. And digital is something that we could, the populations aren't that different, so digital interventions, if we did that analysis for both parts of the island, that would be useful. And then what else do we have? We have the surveillance. We're having ongoing discussions again with the National Suicide Research Foundation, thinking about ways that we can look at real-time monitoring of suicide in the same way in the north and south. We know people do cross the border, and it can be difficult to track them down. We also know that the clustering and contagion of suicides and suicidal behaviour doesn't know any borders. We have exposure to the same media north and south, so arguably even more so than the UK media. We should be working together in safe reporting of suicide, surveillance of suicide in public places, particularly rivers, waterways, things like that, so that we can more effectively monitor patterns and intervene in an appropriate way there. So those are some suggestions. I think the research is really strong. There's also some really strong training programs in the south that we're looking at, training programs for police, for example, and we're trying to have a more joined up crisis service for people in crisis and training for all the agencies there. So there's opportunities for working together for training key people who would be engaged in supporting people who are suicidal.
Yeah. Brilliant. And actually, yeah, I went down to Limerick last week. There was the launch of the Community Access Support Teams, which is a joint venture between the Gardaí and the HSE for mental health crisis. And our Minister for Mental Health, Mary Butler, who's been an absolute, superstar in progressing the work around mental health. There's a new training called Let's Talk About Suicide, and she shared it with all of the Oireachtas members, so all of the TDs and senators in Leinster House. So it's great to kind of have that leadership who is keeping it on the agenda and encouraging people to learn more. I'm going to come to Elaine now. Elaine, so a question actually came in there you're typing an answer to Mark. He was asking about culturally appropriate for deaf people. So I see that Elaine is typing an answer. But my question then was around linking with what Siobhan is saying, and you mentioned as well, some people have to travel outside of Ireland to access mental health services, and we have heard then that it's British Sign Language in the north. So not only are you traveling outside of your home you also then have to learn a new language. So can you just tell us a little bit more? I know you did speak about the challenges, but are there other kind of barriers that are coming up for people accessing services in the UK, if that's where people have to go? And just to remind people that it's going to be a Kerry accent, male voice that you'll be hearing as Elaine answers us.
Sounds like the Kerry man. Is it a bad one? Is the accent bad? Yes, there are a lot of deaf people that go to the UK, and it's because they have the right supports in place, the right mental health services for deaf people. The barriers are they have to move to a different country. They don't have their community, and like the community they would know here would be very different. It's Irish culture here, and the Irish community here. They're then away. It's home away from home. Their family then may not be able to go over. And mental health services need to meet with your family and friends. They wouldn't be able to do that here either. Then deaf people, some people will be able to learn British Sign Language very quickly, and others may not, so they might fall behind there. Then it would be BSL interpreters who may not have an understanding of Irish Sign Language, ISL. And some deaf people are able to adopt to both ISL and BSL, but not all. So that can create a barrier there in terms of communication as well. Then I think that you miss out on your connections as well. They can be missing.
Yeah,
and then sometimes they might have to stay there for 3 months. They might have to stay there for 6 months. They come back to Ireland and they're back to square one. They can dip again. They then have to rearrange another funding opportunity with the HC to be able to fly over. There could be time delays there. And then that can affect them more than in terms of their mental health.
I think for me, when we had the public consultation, even though I've worked in this area for a while and with some of the colleagues in the DPO network, I didn't know that about traveling to the UK and having to learn British Sign Language. And it really shocked me, and it shocked us in mental health reform, which is why we really wanted to give a platform to that today. It's such an important part. We can't talk about suicide prevention without talking about the accessibility for everyone. I'm conscious of time, and we said that we'd wrap up at 12:30. So can I just again say a very big thank you to our brilliant panel of Elaine, Breed, Siobhan and Verona, and also to our interpreters, Willie and Sarah, just to say a huge thank you. I do love to see a good, strong female panel as well. It's wonderful, and we really appreciate your time this morning. To everyone who's joined in and listened, the slides will be saved and shared in a couple of days, along with a recording of the event. Please do go on to mentalhealthreform.ie to see more of our research, reports, policy submissions, pre-budget campaigns. I can never be anywhere with an audience and not mention the opportunity that we all have now with a general election looming. The canvassers and politicians need to hear that mental health is a priority for people. They need this to be said. Everyone who knocks on your door, unless it's coming up on the doors, it's not going to be a priority for government. We can do as much as we can in mental health reform, and believe me, we do. On behalf of our members and people accessing services, but the more of us that are bringing this up, particularly now as you're going to have people canvassing, the better. I promise you there is strength in numbers around this. Just to say again, Stephen, thank you in the background, the support numbers. So it's a really difficult topic. I think most of us, many of us will have been personally touched by this issue. And I work in this I've been working in mental health reform for 3 years, and I found this session upsetting, inspiring, uplifting, depressing, all of those things. So I would really say, please do don't go straight onto calls or emails after this, or don't go straight into a chore of, you know, doing something with the kids or whatever it is. Please take a few minutes, either sit in silence, have a cup of tea, stick on, you know, your favorite song or your favorite TV show. Probably for me it would be The Chase. You know, I love a bit of Bradley. Have a moment of stillness and silence in memory of your loved one who maybe isn't around anymore. Light a candle. Just be kind to yourself and acknowledge that even if you really enjoyed this session and found it very informative, to just give yourself the space now after this. I have to say a huge thank you to Stephen Shield, the project lead on this, and also to Julia, who compiled the submission, Julia Corey. I also have to ask people to sign up to our newsletter and follow us on socials, because we will be doing more on this in 2025. You know, this is not the end of us trying to put a spotlight on suicide prevention. And I think one thing for me, and it's 12:30, so I'm going to leave you with this. Apart from my usual thing where I like to look at dog videos on the internet, that always gives me a bit of a boost.